Hello, I would like to welcome everyone to today's Systems for Action Research in Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title of today's presentation is Rural-Urban Differences in Delivery Systems for Population Health Activities. My name is Shauna Moore, and I'm the Director of Dissemination and Research Development for the RWJS Systems for Action National Coordinating Center. I'd like to go ahead and present today's agenda. We will first introduce our presenters, our commentary speakers, and then we will have a Q&A. I'd like to encourage everyone to type their questions and comments into the left-hand box in the bottom left-hand portion of your screen, and we will address those at the end of the presentation. Dr. Poe is a postdoctoral scholar and research methodologist within the Systems for Action National Program Office. Dr. Poe provides technical expertise in database management. He received his PhD in political science at the University of Kentucky and a BA in political science and history from the University of Arkansas. And our commentary speaker is Dr. Ty Borders. He is the Foundation for a Healthy Kentucky Endowed Chair in Rural Health Policy and a professor in the Department of Health Management and Policy. He also serves as the director of the federally funded Rural and Underserved Health Research Center. Dr. Borders earned a PhD and MA in Health Administration, an MS in Epidemiology from the University of Iowa, and a BA in Psychology from the University of Kansas. His research focuses on rural-urban, racial and ethnic variations in health-related quality of care, consumer reports of care, and health care access. And now I'd like to go ahead and hand the program over to Dr. Poe.
Hello. Can everyone hear me okay?
Yes, John.
Okay. Hello, my name is John Poe. I am a research methodologist and postdoc, like Shauna said. I want to thank Shauna for coordinating this today, and I want to thank Ty especially for being the commentator today. I really appreciate it. This is a paper on rural-urban differences in the comprehensiveness of public health systems. So first off, I want to do some acknowledgments related to the project. I want to thank the Robert Wood Johnson Foundation in particular for funding our research and for funding this project in particular. I want to thank the intramural research team, Glenn Mays, the co-author on this project, and our PI. This project wouldn't have really happened without him, and he's been incredibly helpful, so I really want to thank him very much. I want to thank Nerlin Kusanov, C.B. Mamrell, Dominic Zephyr, and Shauna Moore, all the people who have helped put everything that we do in the intramural research team together. And I want to thank Rachel Hogg-Graham and Rick Ingram, who also contribute pretty heavily to the NLSPHS research. Just to start out, I want to give everyone a bit of background on this project. There are two main research questions that we're centered around here. The first is what differences exist between urban and rural communities insofar as the quality and the comprehensiveness of their health systems, and then what are the drivers of those differences? What actually accounts for the fact that urban and rural communities are very different? We know that they're different from a large body of literature, but just knowing that something is an urban community versus a rural community doesn't tell you anything explicitly about the mechanisms. So a little bit more background. Communities vary pretty widely in their ability to provide public health services for a few different reasons. They have very different resource bases. You can think of this in terms of tax bases. You can think of this in terms of just the availability of resources that they have, that different partner organizations have. They have different healthcare needs in different communities, and they have very, very different institutional structures to support those needs. We can think of the provision of kind of a comprehensive public health system requiring a very heterogeneous set of actions that would be more difficult. We could think of them as being more difficult for rural communities than urban communities. You need to be able to assess population health status and needs. You need to be able to educate the public about health risks and prevention strategies. You need to be able to engage with community stakeholders in planning and implementing health improvement strategies. And you need to be able to link individuals with health and social services based on their needs. These are all things that are directly related to research that Robert Wood Johnson has been funding through Systems for Action, so it's not really new to anyone, but it does have some pretty stark implications for differences between urban and rural communities, where rural communities just can be presumed to have less ability to do all of these things, or they have to prioritize much more. We tend to think rural communities, as compared to urban ones, are just going to have fewer available resources. They're going to have weaker political institutions, and they're going to have very different kinds of public health challenges than urban communities, probably more homogeneous challenges than urban communities. A little bit of background on the NALSYS. First off, you may or you probably have heard of the National Longitudinal Survey of Public Health Systems as the NLSPHS. It has been rechristened the NALSYS, so you will at times hear me call it NALSYS intentionally. I will probably slip and accidentally call it the NLSPHS just because old habits die hard, but it's the same thing. It's the same National Longitudinal Survey of Public Health Systems that a lot of our research is based on. This study in particular is examining local health systems in rural, micropolitan, and metropolitan communities based on the 2016 wave of the survey. The NALSYS has been around as a cohort sample of large communities dating back from 1998, and then those are communities that were 100,000 in population or more from 1998, 2006, 12, 14, 16, and now we have currently in the field 2018. Since 2014, we've had a sample of small jurisdictions or smaller jurisdictions under 100,000, so 2014, 16, and 18. And as of 2016, we've started gathering full statewide snapshots. These are not to say that we didn't already have certain observations, certain communities captured in these states, but now we're trying to fill out the whole states. 2016 included Ohio, Washington, and Oregon, as well as Kentucky. And then 2018 survey includes Ohio, Washington, Oregon, Texas, Indiana, and Kentucky. So we are expanding analysis year by year, gaining the ability to do more and more with it. So we're really looking forward to the 2018 sample. A little bit of background on the specific measures that we're talking about. The NALSYS provides a number of different things. Local public health department officials report on scope, they report on network structures, they report on centrality and the quality of effectiveness and activities. What we do is we take all of the measures. There are a number of measures in the NALSYS that local public health departments respond to about their communities, and we give individual communities ranking, whether they're comprehensive, conventional, or limited. Comprehensive communities are the most well-integrated public health systems. They have the most well-integrated public health networks of providers, and they offer the highest proportion of public health activities. Conventional communities have less integration, fewer activities. They're still doing reasonably well, but they're not at comprehensive status. They're also kind of more typical of communities that aren't really trying to have a lot of comprehensive public health systems activities. And then limited communities are the lowest level of program activity and the lowest amount of intergroup coordination. This metric has been used by Robert Wood Johnson as one of RWJF's Culture of Health metrics. As of the 2016 measure, 47% of the population is served by a comprehensive public health system. So moving on to the project, note that this is a correlational analysis. We don't have instrumental variables in this. We don't have any kind of experimental design. Ensuring that we understand what the mechanisms are at work, mainly variation in available resources and health system partners is going to differ between larger and smaller communities, and those differences are going to drive changes in the comprehensiveness of the health system. We don't really have the ability to test the specific causal mechanism with this design. This is a snapshot for 2016. I've done similar analyses with the 2014 data, and they're pretty comparable. In the future, we hope to use the longitudinal aspect of analysis to build a more causally focused design with 2014, 16, and 18. We want to be able to show change over time within the communities. If anyone has any suggestions on causal inference, especially related to this project, I would welcome that feedback. Just a little bit of information about the variables in question and the stages of the presentation, the stages of the analysis. This is, again, the 2016 wave of analysis. We've combined our instrument with variables from the Area Health Resource File and with NACHO. The statistical model in this case is a multinomial probit. I've done similar analyses with other kinds of similar models. Multinomial logit, structural equation model, they all produce basically the same thing. So I went with the more commonly known model. The dependent variable is comprehensive health system status variable. And again, that is a system is either comprehensive, conventional, or limited. The main independent variable in this analysis is community size. I've measured that a few different ways. We've got one metric that is based on census MSA metrics for is it a rural community, a micropolitan community, or a metropolitan community. Specifically, does the community's county contain a micropolitan or metropolitan ID? We've done similar, exactly the same model specification, just changing community size to be measured as log population and population, just for some robustness. And they do provide some different inferences as well, so I would like some feedback if anyone can give it on kind of what the pros and cons are of using the different measures. The first stage of the presentation is just bivariate comparisons across size. We're just looking at a very simple model looking at an outcome of is the system comprehensive, conventional, or limited, and then an independent variable for community size, and looking at some predicted probabilities and marginal effect differences in graphical form. And I'll walk through the graphs, and then a second stage presentation of a full model specification with a number of variables, percent non-white, percent over 65, percent in poverty, the unemployment rate, is there a local board of health, hospital beds per capita, primary care physicians per 100,000, and are there federally qualified health centers in the community? And so the goal with this approach, the goal with the full model specification, was to see if we couldn't explain away the differences between large and small communities, between urban, rural, and urban and rural communities, micropolitan, metropolitan, and rural communities. We wanted to be able to substantially explain what causes those differences. And we have some mixed evidence. Primarily, I'll jump ahead a little bit, that federally qualified health centers and basically knowing how many hospital beds there are in the community are the primary things that seem to break the differences across community types a bit. So to give you a little bit of a more concrete indication of what we're working with here, health system status is, again, three category variable. In some versions of our analysis, the more common specification is just to say, is it a comprehensive system or not? We went with a more complicated version for the multinomial model of interesting reasons that will become apparent when I show you the plot. But this graph is just showing you the number of observations in the 2016 NALSYS survey across each comprehensive, conventional, and limited category, and then the population size categories. You see metropolitan is the most represented, which makes sense because we started with those and they're easier to recruit to fill out the survey. And then micropolitan and rural communities make up the remainder. So the first graph that I want to show you is just predicted probabilities for marginal effect differences. So this is just showing you essentially what happens when you shift from a rural community to a micropolitan community to a metropolitan community on the probability of it being a conventional system, a comprehensive system, or a limited system. So what we see is rural communities, there's not really that much of a difference in the probability that they will be limited versus micropolitan or metropolitan communities. That seems to be something that's relatively unrelated to size. And again, there are no other variables in this model. This is just a bivariate comparison of these two variables. What we see that's pretty striking in this presentation is that conventional and comprehensive, the probability of being conventional versus comprehensive seems to flip as you get larger and larger communities. What this indicates is that communities that are smaller, more rural communities, are having a harder time getting up to the comprehensive status level. They're much more likely to be conventional because they don't have the same resources, the same number of organizational partners who can be engaged with the community. They don't have the ability to offer as many activities, as many public health activities as more urban communities. So to me, it says it's a resource. It's a resource problem. But again, we don't have the ability to test individual mechanisms from a causal inference standpoint. So we're inferring a lot here. This again is the three-category version of population. When we shift this over to a different measure of population, when we look at the log population, we see a similar story, but a much more expressive story, where we are seeing an increase in probability of limited jurisdictions here. The x-axis, by the way, is in log population, so it doesn't really make logical sense to report it. But these individual dots are measures on the x-axis related to log population. So I took the 1st, 5th, 10th, 25th, 75th, 90th, 95th, and 99th percentiles of log population and just plotted them. That way I have good coverage over the entire range of the log of population size over communities. That's why the tails aren't flaring out at the end, because we're not really talking about areas where there's not a lot of data. So again, we do see some slight differences in the trajectories here. It looks like there's more movement from just treating it as a three-category variable for rural, micro, and metro compared to log population. Limited jurisdictions become a little bit more likely, not very, but we do see the same basic story of conventional jurisdictions. Conventional communities are much more likely for smaller jurisdictions, and comprehensive communities are much less likely for smaller jurisdictions, and at some point those probabilities flip. Those probabilities seem to flip in a pretty consistent way no matter how we are measuring the size of the communities. When we shift it over into just population, we see a pretty similar story. The main difference between this plot and the previous plot is I'm measuring the derivatives at different points. So again, this is the same, 1st, 5th, 10th percentile of population. The only difference is I cut out the 99th percentile so that it wouldn't flare out at the tails and become hard to read. So we're seeing a basically similar story across all three of these versions of population size or across community size types. But definitely the most limited version, the one that seems to indicate the weakest relationship between community size and the comprehensiveness of the health system, is the one with the three categories. So now we can shift into a full specification of the model. Again, this is a model that is supposed to kind of break the relationship between population size or between community size and the comprehensiveness of the health system. Basically, we're trying to explain it away. We're trying to understand what the mechanisms are for what drives a comprehensive community. And we know pretty well from this, from existing literature, that we've got some characteristics of the population in question, the percentage of the population that's a minority, the percentage that's over 65% in poverty. We've got the unemployment rate. Then we've got some specific categories of variables for the health system itself. Is there a local independent board of health? Is the health system centralized between state and local governance? And then what ends up being kind of the most predictive from the resource argument is the variables related to hospital access. Are there more hospital beds per capita? Are there more primary care physicians? Are there federally qualified health centers or not? And so I'm going to take you through comparisons between the bivariate model and the full model just to show you specifically kind of what's changing. And again, this is based on the bivariate comparison. You'll see a note at the bottom that says whether or not the plot is based on the bivariate or the full specification. So this is the plot that we were looking at before. And we see the differences between comprehensive and conventional. Like the trajectories look similar. They look like comprehensive communities are becoming slightly more likely the larger you get, and conventional communities are becoming slightly less likely the larger you get. We're seeing very little movement on whether it's a limited community or not, but in general, the differences between comprehensive and conventional seem to be explained away, or at least become statistically insignificant compared to the bivariate model. This relationship, being able to explain these things, tends to break down a bit once we start looking at other versions of community size, once we start looking at log population. Again, this is the bivariate version that doesn't have any control variables, and this is the version that has full model specification. We're seeing basically the same story. There's very, very little difference in kind of the probability of a community being comprehensive or conventional that is being explained away by these other variables that's not already being explained by population size or the log of population size. Again, this is the version that's based on no control variables at all. We're not talking about any kind of resources available to the health system. We're not talking about the community at all. We're just talking about the size of the community, the log of the population of the community. And we're seeing almost identical stories here. And then again, when we shift over to just a raw population metric, not even the log of population, which tends to behave a bit better in models, we're seeing basically the same thing happen. Very, very little movement between the bivariate version and the full model specification. They were actually so close that I had to keep double-checking my output to make sure that I hadn't made a mistake and actually presented the same graph twice under different names. So just to give you a little bit of a summary, conventional systems appear to be much more likely in smaller communities, and comprehensive systems are less likely in smaller communities. The probabilities flip over time, and this is a really robust result that doesn't take a lot of intuition to be able to understand. it doesn't really matter how we measure the comprehensiveness of the public health system, whether or not it just is the system comprehensive, yes or no, or whether we use the three-measure or the three-category version. This is a really consistent finding, and that finding is, again, consistent regardless of how we measure community size. The more continuous versions, the non-categorical versions of community size are showing a much broader picture. They're showing a lot more information. But even with the more abstracted version of just micropolitan, metropolitan, rural, we're still seeing the same basic picture. When we start to include all these control variables, the picture becomes slightly less consistent for the metro, micro, and rural specification of community, but it's pretty consistent with the others. And it seems to me that understanding SQHC and hospital beds are what is making the metro, micro, and rural version become insignificant. It doesn't seem to have much of a statistical effect on log population or population size at all. And then microphone problem. So yeah, it doesn't seem to have that much, like there's not a way that I've been able to find to explain away the differences between urban and rural communities to date, at least insofar as the specification with the log of population size and population size. So in the future, what we're planning to do is try and build out a longitudinal version of this using the 2014, 16, and 18 waves of analysis to be able to talk about a bit more of what is changing in these communities and try to leverage a little bit more information to see if we can explain away more of the differences between larger and smaller communities. But as of right now, they're pretty stark. Any questions?
Great. Thank you, John, for that presentation. I'd like to go ahead and hand the microphone over to Dr. Borders to give his comments on the topic. Dr. Borders?
Yes, thank you. So I think this is an important topic and contributes to an area that's really underdeveloped. I'm also editor of the Journal of Rural Health, and in that role, I've, of course, read a lot of papers on a variety of rural health topics. I think we get about 360 submissions per year, and it's really the source for information on rural health generally in the U.S. But I mention this because I think we've only received, 2 or 3, a handful of papers over my tenure as editor, which has been for 9 years, on rural public health system issues. So I don't think there's much being done in this area overall. So a few things which I would note. One is, what John has really done here is looked at differences in the comprehensiveness of the public health system across metropolitan counties, micropolitan counties, and then other non-metro counties, which is called rural. And this is pretty typical in rural health research. Usually persons are comparing and contrasting metropolitan versus non-metropolitan counties. Now, just to make sure that we're on the same page, the micropolitan counties are technically considered non-metro also. But I do think it's valuable to have this trichotomous categorization of metro, micro, and then other non-metro, as opposed to simply comparing metropolitan versus all non-metropolitan counties. So I don't think it's too surprising, but it does add to our evidence that the rural or the non-metro counties had less comprehensive public health systems, and they had more conventional public health systems. And as John said, this is arguably because of capacity and resource constraints, just like in the medical care literature, which sort of dominates the rural health literature overall. It's just the fact that small population sizes mean that most rural healthcare systems, whether they're medical care or public, probably don't have the resources or the capacity, or in some cases even the need, to provide comprehensive services. And that's something else I think which is worth is worth considering. To what extent do the rural and the micropolitan counties really need to offer comprehensive public health services, because they just may not have the population size to do that. On the other hand, if they really do need comprehensive public health systems and services, if this would be beneficial, perhaps we need to think more about regionalization across counties or several counties. This occurs in the medical care sector. It probably should occur more, but it would think to me that in terms of public health services and systems, that many counties could come together, many small counties could come together to offer more comprehensive services. And this, I think there's some methodological issues that we need to be thought about in this regard in terms of research, such as how we define what is really the public health system that serves rural areas. It may not be a single town or a single county per se, but I think this would be important to advance our knowledge of how to better organize such services. And then lastly, I think that John is on the right track here. We need to understand more about the underlying factors that really are associated with the public health delivery system across metro and non-metropolitan areas, because that's just really a proxy for other things, right? Metro and micro and other non-metro status just tells us the number of people who live in a defined geographic area. It doesn't really tell us much about what's going on, within those areas in terms of the individuals who live there and the healthcare systems that provide services in those areas. So I do agree that that's an important avenue for future research. Those are the end of my comments, and hopefully we'll have, or John will have some questions, and we can talk a little bit more about these issues.
Okay, thank you both, Drs. Poe and Borders, for your comments in the presentation. I'd like to go ahead and open the forum up for questions and discussion at this time. Again, I'd like to encourage you to type your questions and comments in the chat box in the lower left-hand corner of your screen. I can go ahead and get us started on a few questions. The first one comes in from Phyllis. She says she can appreciate the methodological challenges, but what would you like to revisit in the findings? What should state health departments take away from this? How can we best use these findings to help strengthen our local public health systems? John, do you want to take a approach to this question?
Sure. I think actually something that Dr. Borders mentioned in his last comment that I've been thinking about for a while, partly because in my past life as a political scientist, I studied state and local politics. And one of the things that's kind of struck me over time in learning more and more about public health systems is kind of coordination across multiple counties and how state governments are kind of merging a lot of rural communities into like larger jurisdictions. I think anything that state governments can do to help coordinate across communities to help pool resources, whether that is building kind of omnibus public health department jurisdictions or just building in facilitating communication, facilitating kind of resource sharing and burden sharing across communities, or doing anything to take some of the burden off of rural communities in terms of being able to kind of define what their needs are is probably a good thing. This is something that's done pretty widely in state politics across just a ridiculous number of policy issues for economic development, for public health, for education, for police and like fire services. So it's not a new concept at all. It's something that I think is done quite a bit. But in particular, if there's one thing that these findings seem to hint at, it's that it definitely needs to be done for rural communities. One of the kind of partner organizations in the NALSYS is the state government, where we look at how much the state government does to help provide policy activities or help provide coordination for different organizations. And so I think that state governments can do a lot in this to help kind of shore up some of the deficits that rural communities have.
Okay, thank you for the response to that. I'm actually going to tie into another question that we have regarding community assessment and work. And this one comes in asking about community collaborative work and how community coalition effectiveness and functioning may or may not be associated with public health system comprehensiveness. Has anyone thought about this or looked into this? This person's working on a paper currently looking at how the coalition functioning may vary across community size, but learning about this makes them think there may be more information or more of a story than just looking at community size or rurality.
I'm sorry, you cut off a little bit from my speakers when you were saying the initial question.
Oh, that's okay. I'll repeat it. This one comes in asking about community collaborative work and how community coalition effectiveness and functioning may or may not be associated with public health system comprehensiveness. So they think there may be more of a story than just looking at community size or rurality. You want to talk about that a little bit?
Yeah. One of the way that we build the comprehensive systems metric is fairly complicated. But one of the things that we look at is whether or not different organizations are active on specific activities. And we try to build measures of kind of network density and centrality relating to activities. We don't have, individual surveys to all of the different partner organizations available. So we're kind of limited in our ability to talk about a lot of coordination, a lot of relationships between communities directly, but we infer it from whether or not the different partners are active. So I think there's a lot of really important qualitative study that needs to be done to unpack a lot of what we can find in our survey. There's definitely a lot of work that I would want to read to try and explain some of the network interactions a bit more qualitatively focused than what we're able to unpack just from what we've got.
Okay, great. Thanks, John. We do have another question that has come in from Maria. She likes the idea to push counties to work together or to incorporate resources. She's actually working in Georgia where they have 108 rural counties out of 159, so a lot of rural counties. What does that mean for upcoming researchers who want to focus on decreasing health disparities in rural areas? How can we push public health structural changes in somewhere like Georgia?
I mean, I can kind of comment generically as a political scientist in that, like the easiest way from my perspective is just kind of direct lobbying to get improved funding for coordination through the Georgia legislature or something like that. In terms of like building up kind of informal mechanisms that aren't going to require state funding or state coordination, that's something else that you could do. I remember from a previous Research in Progress webinar where people were looking at like coordination of different organizations. There were a lot of different kinds of ways to build organizational cohesion and kind of coordinate across organizations. Some of them were to build like specific nonprofits that their entire job was to coordinate across other organizations. You could do the same exact thing with rural communities and just have a single state nonprofit that isn't funneled through the state government at all and their entire job is just to try and coordinate across different communities in a place like Georgia with 108 rural counties, and to have regular webinars where people can talk about problems that they have in common, or issues that they have in common, or strategies that they've come up with. So even things that aren't like directly filtered through like officially changing governmental organizations should still have a lot of impact if they're done well.
Okay, great. Thanks, John. I'd like to go ahead and ask you about future analysis directions and opportunities utilizing the 2018 NALSYS wave. We've added more statewide surveys in this new wave, and I thought maybe you could touch base on some of your ideas going forward with this research.
Yeah, so that gets back to a couple of Dr. Border's comments about kind of coordination across different communities and kind of better defining what a community is. One of the things that I would really like to do with our larger state samples is to get a little bit more creative about how we're defining communities, and to be able to talk specifically about kind of diffusion of activities across communities, or if there is coordination across communities, being able to model that in a more theoretically driven way. Right now, we tend to treat communities as essentially independent of one another because NALSYS is a national sample of communities. There are a number of communities in any given state, but we have to treat them as more or less independent because we just don't have very many in any given state. That said, once we start looking at entire state populations of public health systems and communities, we should be able to get a lot more creative about kind of what are the effective boundaries of organizations, what are the effective boundaries of networks, and how do things like hospitals, for instance, coordinate across multiple communities at once in rural areas where maybe there isn't a hospital in this particular county, but 3 counties over there is. So they're part of a system, even though they're part of a community, even though they're not within that community's regular borders as we normally think of them.
Okay, great, John. Thanks for the insight. I see that we are actually out of questions and comments, so I'd like to encourage anyone, if you think of any questions or comments, to please email the PI directly. You can find contact details for all of us at systemsforaction.org. I'd like to thank both Drs. Poe and Borders for presenting today and for discussing this interesting topic. We'd like to encourage everyone to take a look at our upcoming webinars. We have one coming up from researchers at Columbia University Wednesday, October 3rd, that will be looking at testing a new terminology system for health and social services integration. We'd like to go ahead and acknowledge that support for this webinar and Systems for Action National Program Office are by the Robert Wood Johnson Foundation. Systems for Action is a national program office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. It looks like we are ending a little early today, so we can give you a few minutes of your day back. We really appreciate you joining us, and we hope to see you online in the future. Thank you very much.